About peroxide and peroxide. Most of us, I think, when we think peroxide, think ClearCare, because to me it is the gold standard. It's what I think of. I use the term peroxide, but I'm really thinking of ClearCare. The question is it different than just peroxide, and what makes it different than peroxide? Any thoughts? Any takers on that one?
I've actually asked the people in industry that question, and they tell me there is a tremendous difference based on, I guess you call them not pollutants, but there are molecules in, say, store-bought hydrogen peroxide that are not good for the contact lenses, that cause these color changes, etc. Those are definitely not present in ClearCare. They've gone to great lengths to make sure that what you're getting is hydrogen peroxide, and just about that's all there is.
But what about
optical grade peroxide is very different than commercial grade peroxide.
But let's get more specific. What about relative to some of the generics I mentioned, or to some other products? We think of peroxide as peroxide. Is ClearCare a unique formulation?
As we know, when we think about other generic medications and drugs that are on the market, even though aspirin may be aspirin, right? It's the other things that are added to the product that will change how that product works. So it might not even be what's considered an active ingredient. It may be some of the quote-unquote inactive ingredients in there. And this is true whether you're talking peroxide or whether you're talking multi-purpose solutions, right? So the biggest thing that makes a difference is the addition of, say, surfactants or the floronic into the product.
Good. Okay.
One of the other things that we didn't mention, but that we probably should talk about, is residual peroxide levels, and that they do vary with the age of the disc.
We actually did refer to it a little bit. While you were sleeping, Grants. While you were sleeping, Grants. We did talk about it. And again, I think that's very, very important. I think that's going to become a big issue as peroxide becomes more common. And again, I guess most of you realize that peroxide's doubled since the fusarium and acanthamoeba outbreaks. I don't know. It's important for our readers to recognize that peroxide has actually doubled in use. From about 8% to about 16%. Largely because of that trust in the product. And but I think that the point that Chris, I think you made very, very nicely, is that there are significant formulation differences. ClearCare wasn't something that was cobbled together by accident. It was actually made very, very carefully. It was formulated to be an advanced product, which I think has made a difference. So I want to talk about corneal infiltrates. That's a very, very hot topic. I know it's one that's near and dear to your heart, Loretta, and it's certainly, I think, near and dear to many of our hearts because of the barrage that we've been seeing about corneal infiltrates. And then I want to end this by talking about practice and patient management. But are corneal infiltrates that big an issue, and where are corneal infiltrates coming from? Is it a solution-related thing? Are we seeing it with peroxide? Is this a sudden epidemic? And what's going on, Loretta? It's by the way, that's sort of a hand grenade. Loretta?
Well, infiltrates are a very big deal in extended wear. In extended wear, the rates are really not acceptable, I think, for the average practitioner to be able to handle and manage that. In daily wear, I think the rates are rather low, very low, and manageable. So we don't see as many symptomatic infiltrates. We see asymptomatic infiltrates in daily wear at a reasonably low level. There are these hypersensitive patients that seem to be sensitive to lots of things, and peroxide's probably a good option for them, or daily disposables. Across the board, in large-scale retrospective studies, peroxide is always always has lower infiltrative responses than any MPSs as a group. So Chalmers has done at least 2, if not 3, large retrospective studies of thousands of wears, and it's always been significant. Peroxide has definitely a lower rate, as well as the studies that are coming out from Australia. The current studies also show that peroxide has the lowest rate. Now, it's not immune to infiltrates. So infiltrates can also occur in peroxide users, but when they do, they're not due to hypersensitivity to the product. They're due to patient factors, and that is usually bacteria that come from the patient, either their hands or their lids. And we've actually even been able to isolate it to normal flora. So there are patient factors we can't get away from in infiltrates. And regardless of the product that they're using, because the last thing that touches the lens before it goes in the eye is the hands or the lid. And if there's significant bacteria on the hands or the lid that cannot be handled by the system's immune, well, actually it is being handled by the host's immune system, and what you're seeing is the infiltrate coming in and attacking the bacteria on the lens that came from, the patient's own handling or their own lids. So you can't get away from infiltrates because of patient factors.
I think that's a great point. I think we've hyper-focused on contact lens solutions as being the source of many of the infiltrates that people are reporting, which is odd because you have practices where there are no infiltrates at all, despite using a solution that's been questioned, and yet other practices seem to have a lot of them. And in my experience, the vast majority of infiltrates are from staph exotoxin or from normal flora, and you're exactly right. It's the body doing what it's supposed to do. It's responding to those alien proteins by sending in white cells to defend against those things. And to your point, peroxide produces the least amount, probably, at least in part because of handling issues and things like that. So I think it's multifactorial and there are many, many factors. But again, it goes back to the gold standard. If you have a patient where you have a history of infiltrates and you're concerned, certainly peroxide has the lowest rate of infiltrates.
And I think what Loretta just said
It's
is
Chris.
important. I am more likely to prescribe a peroxide-based system for my patients that have what I consider to be significant lid disease, because I think they will have the best reaction to that, as opposed to, say, the dry eye patient who may actually do better in an MPS solution. And I think that goes back to, it's important to not have sort of this knee-jerk prescribing. And one thing that really bothers me when I see patients or doctors talking about peroxide is they either will frequently use the word, "it's my problem solver," meaning that they only use it when they see problems and then change patients into peroxide, or they have this knee-jerk reaction and prescribe everything.
Yeah.
And I think we need to focus on intelligent prescribing, which is focus on the patients that may most likely have the problem, put them into the first-line choice.
Okay.
We're getting an echo on
Yeah,
you,
we get-
Chris.
Chris, have you suddenly moved to Beijing? All right.
I am getting a lot of feedback.
Okay.
better.
Well, so it's better now. Everybody separate their phones. Bill, keep the dog quiet. Oh no, actually, it's me feeding back.
You want me to be quiet or you want me to say something?
All right. Okay, everyone on the phone, guys. Shh. Chris.
Yeah, I think some folks are barking up the wrong tree a little bit, looking at solution specifically causing infiltrates. I was asked that question several times the past couple of years.
I'm pretty sure their speakerphone is on the other side. That's what we're hearing.
Yeah. If someone has a speakerphone on, could you turn it off? Bill.
I don't have a speakerphone.
Okay, Chris.
No.
Okay. Well, we've troubleshot that.
My phone. I don't know. I suddenly can't hear you. Is that-
Okay, that's very strange. Okay, 319 is Chris. Okay. Okay, you can't hear anything. Echo, echo, echo. Okay. Hold on. Okay.
You're the echo. We're the echoes.
We're the echo. So how do we? Okay, how do we deal with? So anyway, so as I was saying, we were walking down a long road. Anyway.
Yeah. What I was saying is I think that we're barking up the wrong tree a little bit looking at solution-induced infiltrative response. I was asked that question several times over the past couple of years, and I hadn't seen it personally, so I dove into our EHR and pulled every time an infiltrate was diagnosed and tried to look at the history, and I didn't identify it being related to a solution. The lion's share of our patients use the OptiFree Pure Moist brand with a smattering across brands after that, and I have absolutely not seen that. And in fact, just exactly what Loretta and Chris said, I believe it absolutely to be lid-induced predominantly.